So I'm gonna talk briefly about hepatitis C issues on hepatitis C. This is my financial disclosures. Briefly, I will try to review the current landscape of hepatitis C on liver transplant. So we are in an exciting time on hepatitis C because we have these new agents that are awesome and that actually cure the disease. And well, for those people who had to treat patients with interferon and the new protease inhibitors, this is completely simple right now. So there's places in the States and elsewhere that even primary providers can treat the hepatitis C. And well, the hepatitis C pool on the liver transplant list nationwide is decreasing because we are being able to cure these patients. But right now there's other interesting stuff in the subject. So, well, we treat patients pre-transplant, post-transplant. So there's pros and cons on both sides. We're going to review that. We're going to review briefly the pre and post liver transplant treatment regimen. So there's plenty of resources website and on the website that you can use, and they're handy. I guess you have more experience treating co-infected patients, which is more difficult, and you have plenty of experience treating hepatitis C. We can talk a little bit about retransplantation on patients with hepatitis C, which has a pretty high mortality before, but now people are more willing to retransplant patients that you can cure with the new agents, and you don't have those awful interactions with the immunosuppressors. And something that is happening not just on liver transplant, also in kidney transplant, heart transplant, lung transplant, is the use of hepatitis C positive donors for hepatitis C uninfected recipients. So this is a pretty interesting topic, especially areas where there's not that plenty of donors, and we need to expand the donor pool. So as I tell you before, still hepatitis C comprehends 40% of the current liver disease in the United States. But as you can see in this graph, which is from UNOS, the people with hepatitis C on the waiting transplant list is decreasing. And well, just in the 2015, this bar is the people with alcoholic disease. There's more people on the waiting list with alcoholic disease compared with hepatitis C. That is because after 2014, 2015, we start having very good DAA agents, and we have been able to treat people even with decompensated chronic liver disease. And this third bar here, you can guess what it is NASH, which is a new epidemic. We don't have any medications already. So this is our new nemesis and transplant. But still is an important disease in terms of liver transplant. Recurrence of infection is universal after liver transplant. Actually, you can measure viral load hours after transplantation. So as soon as you do reperfusion, the new organ is going to be infected on a recipient. And actually, there's hepatitis C on monocytes in the recipient. So hepatitis C used to be a major cause of graft failure if not treated. And actually, well, patient can be infected with hepatitis C, and as doctor just told you before, so he's going to be spent like 20, 30 years until he develops cirrhosis. But on transplanted patients, that may happen in 5 years. And actually, 10% of the patients are going to develop the fibrosis cholestatic hepatitis, an aggressive form of the disease that fortunately we don't see anymore. And when we see it and we start new therapy, we can cure those patients. Those patients, inevitable, they're going to die before. And that's what the people that we were unable to retransplant, because the risk of reinfection and more aggressive disease was pretty high. Well, treat or not to treat liver transplant. So it's going to depend on a lot of factors. And actually, this is as per opinion because still we don't have a lot of data yet. So we know that there's observation studies, and this is from the published in the Journal of Hepatology, this experience of the European countries where after 2015 there was a drop from 70% to 30% in the waiting list after they start doing the DAAs, and the people improving the list, and they delisting those patients because they're not needed the transplant anymore. So they have those persons who still doesn't have this bad portal hypertension and encephalopathy that you can start in a DAA. You can reduce the MOL score of them less than 15, and they will never need a liver transplant. We cannot forget that those people still need surveillance for hepatocellular carcinoma if they already have cirrhosis for the rest of his life. And you should do surveillance with sonogram and AFP every 6 months. But unless you can take out a bunch of people from the list, what are the people or the factors that probably gonna increase the survivals on those populations? Maybe there's few studies. This is a study in the gastroenterology. They look at the factors that increase the survival on people who were on the waiting list and receive a therapy. And a low MAS score, a low Shai-Put score, which is more objective score. You look at the encephalopathy, the ascites, in combination with albumin and bilirubin. For those not familiar with the MEL score is the only objective measure that we use to put the people on the transplant list, and it's a formula that takes into consideration the creatinine, bilirubin, sodium, and in the score. And we know that people who has 15 or above that will benefit from a liver transplant. And of course, it doesn't have significant complications of portal hypertension. But you need to take in consideration also your region. There's some people that you're gonna put them on treatment, but they're gonna reduce maybe 3 points on the MEL score, but still they're gonna suffering from portal hypertension, encephalopathy, and that creates what we call a MEL purgatory. So there's these people that the MEL score is not that fair with them, and they're pretty sick, but you reduce the MEL scores a little bit, and they're gonna be lower in the list compared with other patients. And they can stay there waiting for a liver transplant. So there's another study in the annals that show that the MEL score between 23 and 27, when they receive treatment, they have a survival benefit, just looking at the MEL score, but that was the only observational study, has a lot of bias. So who should you treat depends also in the region. If you're in a region which has a very long waiting time, so probably you can treat those patients who can get out of the list, and you're gonna stop the inflammation, and doesn't have a lot of comorbidity waiting for a liver transplant, can be a benefit for them. But if you have a pretty sick patient who has a childhood type C, has a lot of ascites, has a lot of portal hypertension, those are the things that correlate with a worse survivor SVR, sustained virological response, and you can hypothetically select for adverse mutation on those patients and fail for liver transplant. So if you have a pretty sick patient that is high on the transplant and on the list because has a very high MEL, it's pretty sick, and you can say that maybe he can receive an organ in 3 or 6 months. Maybe you should wait and treat those patients after the transplant. And now these DAAs are so good, that has some not important interactions with the immunosuppressors, that you will be able to cure those patients after liver transplant. They're gonna be okay. So you need to take in consideration your waiting time in your area. So for example, in our region, we are a short waiting time region, So sometimes you can stand still and wait until the transplant and do the treatment after that. More now that we have more availability for agents in terms of health insurance, so fortunately this year, so the Medicaid sponsored patients will have access if they have an solid organ transplant, so that's pretty good for our population. Also, there's another consideration to take in areas with long waiting time. So if you're willing to use hepatitis C positive donors who doesn't have advanced fibrosis, who are young donors, so achieving an SVR before transplant, you're gonna take all the donors with hepatitis C positive aside from the pool of donors. So those recipients will be unable to receive a positive donor. So they may need to wait a little bit longer. And there's plenty of data that survival is similar for patients who receive an organ from a hepatitis C positive donor, and even if they're uninfected. So this is completely changing the landscape of hepatitis C and liver transplant. And we are gonna talk a little bit about this on hepatitis C infected donors, on unaffected recipients in other organs, also in kidney. There's a lot of centers that have started accepting organs with hepatitis C positive. So in this new era, so for those people who are older, 50 or plus, so they can remember how was treating people with interferon, especially post-transplant patients, was pretty tough. So those patients developed these immune reactions to the graft, and it was pretty dangerous. There's people that start using with the early DAAs of boceprevir, telaprevir, treated patients with transplant, but they have these strong interactions with the immunosuppressors. So sometimes you do a 0.5 milligrams of Prograf every 15 days for those patients. And you need to bring those patients daily to the transplant center to do tacrolimus levels because the toxicity was pretty high. So we remember treating a patient with one of the first agents. I just give one tablet of 0.5 for 20 days. It was pretty stressful for us. Now, after 2014, 2015, so you can feel comfortable using HD positive donors because you can use those new agents, and this pool of donors is increasing significantly. Well, not everything is completely good, so we know that the survival is different, depends on the factors in the donor. So hepatitis C donors who are older than 45, so the survival is different compared with people who are donors with hepatitis C donor with less than 45 years old. Of course, there's an issue of senescence of the liver of the donor, and of course, people who are older, maybe they have been spent more time with the infection, have more fibrosis. So these are the two factors that you need to take in consideration in terms of what graft you want to get from the pool. So usually you will like to have a younger donor who is Hep C positive, has NAT positive, even antibody positive. And interestingly, this pool of donors is increasing because these are the people who die from overdose in the United States, and there's an epidemic of use on narcotics in the United States. So interesting, there's this paper who said that in 1 year there was a significant increase in this pool of donors. But there are good organs that we can use, not just in liver, also in kidney, if we have availability of the new agents. So the optimal approach is not defined. So it's going to depend on your patient. It's going to depend on how sick the patient is, how rushed you are in doing the transplant, what is the reason of the transplant, what is your region, what is the access of therapy. So usually there's some guidelines. You can recommend therapy on patients who has a low score of MELD score. Some people say 20. Of course, this is going to be this is going to depend on your region, because if your mean score for transplantation is 22, maybe you will need to you will like to wait. But these people with childhood A, B, which are compensated cirrhotic with low MEL, maybe you can treat them and you can avoid a liver transplant, which still is a disease that is going to increase your expectancy of life, but it's a disease you need to use immunosuppressors the rest of your life. Your risk of cancer is higher than the regular population. Of course, we expect you to have a better quality of life, but so being transplanted is not like going to the pharmacy and take another bottle of pills. So, of course, people who are going to be recipients of living donors, maybe you can get rid of the virus before the transplant is going to be much, much better, and the timing is more predictable. Or, of course, people who are on the list because of exception points. For example, if you are pre-compensated and you have hepatocellular carcinoma, but your MEL score is pretty low, maybe you will be able to treat the patient. He can go through a transplant without virus, and he's going to get a liver because the section point is going to put this patient higher on the list. So you avoid the complications of getting through the transplant with hepatitis C. If you have a decompensated cirrhotic who has hepatocellular carcinoma, who is going to wait more than 3 to 6 months, maybe you will like to treat the patients also. You should defer therapy in people who are pretty sick with portal hypertension, pretty high MEL. Of course, if the life expectancy is low, you will not like to do the DAAs also. So you can select there's higher risk of failure of therapy, so you can select for mutations and you can avoid complications also. CPT, B, and C, and renal impairment. So these are the patients who are going to be pretty hard to treat. So we have agents right now that are approved for people who are end-stage renal disease or have a GFR less than 30. But although there's case studies, still the Sovaldi-based agents are not approved by the FDA on people who has a low GFR, although probably we're going to see that on that pretty soon. Advanced compensated cirrhosis with an anticipated wait time less than 3 months, so maybe you should defer therapy, go through transplant, and then treat it. And also, decompensated cirrhosis with HCC with an anticipated waiting time less than 3 months, so you can wait. So the pre-transplant regimen is going to depend on your genotype, your degree of hepatic function, cirrhosis, comorbidities, if it's a patient who has a low GFR. As a general rule, you should avoid protease inhibitors on the compensated cirrhotic. So, and right now that you have very good options and agents, you should avoid that. Those patients should be treated in a collaboration with liver transplant centers. Still, Sovaldi-based agents, there's a risk of decompensation or acute and chronic liver failure when you're doing treatment, and you should be prepared to speed up a transplant evaluation if that happens. So this is now probably the kind of patients that we get a referral to a transplant center, because right now all the GIs are pretty comfortable treating the patients in their office as before even the cirrhotics, but usually they refer the patients to the transplant center to us know the patient before start treatment. We should not use an interferon-based regimen if you have the new DA agents. This is part of why we should not do that anymore. In terms of post-transplant clinical course without therapy, of course, there's a universal reinfection on patients after transplant. The survival is lower in patients who are transplanted with hepatitis C, is comparable with people with alcoholic cirrhosis, hemochromatosis, but it still is lower than people who doesn't have hepatitis C. And the progression is more fast after liver transplant. There's an issue of senescence, there's an immunological issue. So 10 to 30% of those people is going to develop cirrhosis in just 5 years, and they will need a new transplant, they're going to die. So that's the old data. Right now, with the new agents, we are pretty effective getting rid of the infection. And those people, we are going to see what is the long-term survival of these patients, because the first non-interferon DAA started in 2014, 2013, we started Cosmos trials. So still we need to see what happened 5-10 years, but the data is reassuring. What are the risk factors for advanced progression after you do a transplant? And hepatitis C patient is going to depend on the recipient characteristics. We know that female, African American, non-CC, IL-28B genotype, all those factors increase the risk of a fast progression of fibrosis. There are some donor characteristics also, as we told you before. So if the donor is an older donor, even it doesn't have any hepatitis C, reinfection is going to progress the disease faster. And also, if fibrosis is one of the two factors that are pretty similar in all the studies. And has been talk about viral characteristics, about genotype 1 and high viral load, but the data is conflicted about that. But particularly with genotype 1, we see that. Still, genotype 1 is the more prevalent in the United States. So what we need to do when we have a post-transplant liver patient who has hepatitis C, so we need to get a PCR hepatitis C. How early we can start DAAs on this population? Well, as early as the patient can be compliant with the DAA. So if that is the first month, we can start the first month. Usually, if there's no rush to treatment, we wait until 6 months, because that's the time that usually you see the historical complications or other complications of the immunosuppressor. So you want to have this patient on a stable regimen of the immunosuppression, no surgical complications, in order for the patient to be compliant with the DAA. Of course, on those people who were in the pool of post-transplant patients before 2015, so we are treating those patients right now with DAAs. So there is an issue with the restaging of these patients. Of course, the treatment may be different if the patient is cirrhotic already, it's not cirrhotic. So what is the best way of do staging of disease on those patients? Well, the non-invasive markers are not that good in those populations. Upper score, fiber test, fiber sure is not that sensitive on those populations. Non-invasive techniques like elastography are better. Of course, you need to be prudent. Don't do elastography on a patient who has 1 month or 2 months post-transplant. It's going to look like a cirrhotic patient. The liver is going to be hard because it was on a cold table a month ago. So those techniques are you can use, and they're good in patients who have been transplanted for a long time. And they correlate with the liver biopsy. Actually, right now we are using liver biopsies less. So if I'm pretty sure this patient doesn't have cirrhosis, is 6 months, 1 year post-transplant, I don't do biopsy even if the liver enzymes are increasing. So of course, you have also the risk of rejection. But if you can get rid of the hepatitis C in 4 to 12 weeks, so you can wait. So it's pretty hard to lose a liver for rejection. So liver is, I may be biased, but I think it's the most noble organ in the body. So it's not that with kidney rejection is pretty important. So you can wait and do the treatment of hepatitis C and look how the liver enzymes behave. Of course, if you have a high concern of a moderate to severe rejection, maybe you will like to do the liver biopsy, but then you will need to harass the pathologist because he will say, well, has hepatitis C and rejection, both stuffs. He say, well, what's most important in this liver biopsy? So that's the issue with the liver biopsy. It's not that easy to do interpretations on liver biopsy. So a lot of centers do treatment ahead as soon as the liver enzymes are increasing. There's markers of inflammation and the people is able to tolerate the DAA regimen, so you go ahead and start treatment. In terms of the post-transplant regimens, I will skip that part because This is from the AASLD and IDSA site. I think it's excellent. It's handy. You can put in your iPad on your smartphone and you can find that pretty easy. There's FDA-approved regimens for treatment. And actually there's non-FDA-approved regimens that we use frequently and are pretty effective. So a lot of centers have been using ledipasvir and belaspaspir, Epclusa, and there's no FDA-approved data, but it's useful. Of course, you would like to use maybe regimens for people who has a low EFR. Try to use those agents that doesn't have problems with renal excretion. So you have options in terms of treatment right now. In terms of investigational therapies on HCC and infections, so there's those pilot studies about start DAAs from the day one after transplant, even doing that the same day of the transplant. And maybe you can decrease the treatment in 4 weeks. And actually there's this pilot project, I think it was in the University of Pittsburgh. They start doing DAAs from day one. They use a Sovaldi-based treatment, and they were able to get rid of the virus in just 4 weeks with that regimen. It was pretty effective. So I remember there was this huge research with immunoglobulins for hepatitis C. I haven't heard anything about that because the treatments are so good that was so expensive that everybody loses interest about it. I think it's not gonna happen. It's like the hepatitis A immunoglobulins. I don't think anybody used that, but they just go to vaccination. But there was some trials about that. I don't think it's gonna be cost effective because even the immunoglobulins, the projected price was even higher than the DAA. So in terms of retransplantation, there's no guidelines. All depends on the center. Centers are doing more retransplantation on people with hepatitis C cirrhosis on the graft. They feel comfortable doing that with the new DAA agents. We have done some in Puerto Rico, and we had some retransplanted patients with hepatitis C, and his outcome has been pretty good post-transplant. Of course, historically the survival was worse, but now we are in a new era. So, and the survival was so bad before the DAAs that there are centers that not even consider the patient for retransplant. He has a cirrhosis after transplantation for hepatitis C. Fortunately, the need for retransplantation for hepatitis C after transplant is gonna disappear. In terms, does this slide in patients with hepatitis C on an uninfected donor? Of course, the proportion of hepatitis C positive donors to hepatitis C recipient has increased, and we need to take in consideration the age and the fibrosis stage of the donor, as I told you before. And we consider right now appropriate and an urgent need to use hepatitis C viremic donor in an uninfected recipient. And that is even happening in other solid organs, models like kidney. So if you have a patient with acute liver failure that he can die in hours, and you have an opportunity and you have an offer with a hepatitis C donor, which is a good candidate, a young guy, 40 years old, with hepatitis C positive NET, I will use the liver. It's gonna save the life of the patient, and then you can use the treatment with the new drugs. In terms of kidney, historically the survival of hepatitis C infected donors on hepatitis C uninfected was worse. Still, the survival was better than those who stay on the list, in the kidney list. That's the reason that a lot of centers use also hepatitis C donors, especially big centers that, that the bad numbers doesn't hurt the statistics, unfortunately. So there was these 2 small pilot studies where they used hepatitis C donor and hepatitis C uninfected patients in the era of the DAAs. The first one has like about 20 patients, and the second one has about 10 patients. That was published. One was published in the Annals of Internal Medicine, the other in the New England Journal of Medicine last year. All the patients achieved SVR after 12 weeks. There were no allograft reaction on the kidney, and they measured quality of life on the second study of the patients, and it was comparable with the population that doesn't have this problem. So take-home message: hepatitis C is still an important cause of chronic liver disease, although decreasing number on the liver transplant list. Hepatitis C recurrence is universal, and all hepatitis C infected recipients should be treated right now. You should consider factors when taking consideration to start treatment pre or post-transplant. That may be recipient factors, region, availability of medications, availability of organs, expected time on the transplant list. And hepatitis C positive donors on hepatitis C negative recipient is a new and acceptable alternative in the new era of DAAs. Thanks for the invitation.